When a patient experiences 3 or more consecutive premature ventricular complexes, or PVCs, at a rate greater than 100 beats per minute, the patient has ventricular tachycardia, or VT, also known as VTAC. Like a PVC, ventricular tachycardia, or VTAC, originates from an ectopic focus in either ventricle and is a potentially life-threatening rhythm. Sometimes there can be visible P waves popping up randomly during ventricular tachycardia. If they are visible, they march out at a regular normal rate but are disassociated with the QRS. This lack of relationship is called AV dissociation. Let's examine the basic ECG characteristics for a patient with ventricular tachycardia. Rhythm, basically regular. Rate, ventricular rate is regular and greater than 100 beats per minute, but the atrial rate is not discernible. P waves. If there are P waves, they are disassociated with the QRS. PR interval, none that is measurable. QRS, wide complexes equal to or greater than 0.12 seconds. Ventricular tachycardia may be associated with heart disease, particularly myocardial ischemia and with coronary artery disease. Some other causes of VTAC include digitalis toxicity, trauma, electrolyte imbalance, cardiomyopathy, and acid-base imbalance. Ventricular tachycardia requires immediate attention. In assessing the patient, check to see if there is a pulse, which is particularly important in this instance because ventricular tachycardia may present with or without a pulse. If the patient is stable and has a pulse, treat with oxygen, 12-lead ECG, IV access, antiarrhythmics, or elective cardioversion. If the patient is unstable but still has a pulse, prepare for immediate cardioversion. Of course, if there is no pulse, call a code and initiate CPR. It is often difficult to distinguish between an SVT with an interventricular conduction delay and a ventricular tachycardia with a wide QRS, but you should always play it safe and treat it as a ventricular tachycardia until proven otherwise. Another thing to remember when identifying the problem is that it is possible for ventricular tachycardia to present for a brief time, less than 30 seconds, before it reverts to the prior rhythm. This is called non-sustained ventricular tachycardia. A sustained ventricular tachycardia lasts longer than 30 seconds. Remember how atrial fibrillation creates a chaotic rhythm originating in the atria? Well, ventricular fibrillation, or VFib, generates the same kind of disorganized rhythm in the ventricles. Multiple foci in the ventricle become irritated and generate uncoordinated, chaotic impulses that can cause the heart to fibrillate instead of contract, and there is no QRS, no contraction, and no depolarization. Ventricular fibrillation, like ventricular tachycardia, is a lethal rhythm. The ECG for ventricular fibrillation shows chaotic deviations with varying amplitudes and shapes. Patients who generate VFib with low amplitude waves of less than 3 millimeters are labeled as having fine VFib. Likewise, those with waves in excess of 3 millimeters are described with the term coarse VFib. Let's look at the basic ECG characteristics for a patient with ventricular fibrillation. Rate cannot be determined because there are no discernible waves or complexes to measure. Rhythm, rapid and chaotic, with no pattern or regularity. P waves, not discernible. PR interval, not discernible. QRS, not discernible. Ventricular fibrillation is generally present with cardiac arrest and is most often brought about by myocardial ischemia. At this point, the patient will be unresponsive and will have no pulse.
Both pulseless ventricular tachycardia and ventricular fibrillation patients require immediate response. You must call a code and begin CPR. Defibrillate immediately. After administration of initial shock, begin CPR for 2 minutes, then reassess rhythm and pulse. The 2015 American Heart Association Science Guidelines recommend immediately resuming CPR because the most common post-defibrillation rhythms are asystole and pulseless electrical activity. Good CPR is incredibly important because it is the only thing keeping the heart beating, and we need to get oxygen to the brain and the heart. Follow the current acronym, CAB, for compressions first, followed by airway, and then breathing. Prior to intubation, compression to ventilation ratio during CPR is 30:2, with a compression rate of 100 to 120 per minute. CPR should be continued the entire time the patient is being resuscitated, except during defibrillation. You should also establish a large bore IV access for drug therapy. Isotonic IV solutions such as normal saline or lactated ringers should be administered once access is established. Next, initiate pharmacological therapy. The recommended sequence is to administer vasoconstrictive agents during CPR for 2 minutes, 5 cycles of 30:2, then reassess, defibrillate if necessary, resume CPR for 2 minutes, and consider administering antiarrhythmics, reassess, defibrillate if necessary, and resume CPR. Follow this pattern, alternating the 2 types of drugs, vasoconstrictors and antiarrhythmics. AHA 2015 guidelines recommends 2 shocks, then administration of epinephrine. Review lab and arterial blood gas results until it is time appropriate to give the next drug. The first-line drug to treat pulseless ventricular tachycardia and ventricular fibrillation is the vasoconstrictor, epinephrine. Epinephrine is given as a 1 milligram dose IV IO. There is no limit to the amount of epinephrine you can administer, and the dose can be repeated every 3 to 5 minutes. Amiodarone may be administered for patients with ventricular fibrillation or pulseless ventricular tachycardia who are unresponsive to CPR, defibrillation, and a vasopressor. Effective antiarrhythmics include amiodarone, lidocaine, and magnesium. Reasons not to give amiodarone would include a lack of IV IO access, patient allergy to the medication, or severe pulmonary fibrosis. IV access is the only way to administer amiodarone because it is a very thick substance. To use it, you will need a large needle and a 20 milliliter syringe. Administer 300 milligrams IV IO for the initial bolus, and an additional dose of 150 milligrams IV may be given in 3 to 5 minutes if necessary.
When the supraventricular pacemaker fails to fire an impulse, an ectopic area in the ventricle initiates a beat called a ventricular escape beat. This beat actually prevents a more extreme slowdown or asystole from taking place. When a patient experiences 3 or more consecutive ventricular escape beats at 20 to 40 beats per minute, the patient is experiencing ventricular escape, which is also called idioventricular rhythm or IVR. The beats rate is reflective of the ventricle's inherent impulse firing rate, which is not adequate to sustain life. If the ventricular rate slows to less than 20 beats per minute, the rhythm is sometimes called an agonal or a dying heart rhythm. The ventricular rate is 20 to 40 beats per minute. Because these beats originate in the ventricles, Therefore, circumventing the regular conduction pathway, they generate QRS complexes that are wide and bizarre. Let's look at the basic ECG characteristics for a patient experiencing idioventricular rhythm. Rate, 20 to 40 beats per minute. Rhythm, ventricular is basically regular, but the atrial, if present, is unrelated to the ventricular activity. P waves, does not produce a visible P wave because the origin of the beat is ventricular. PR interval, not applicable. QRS, equal to or greater than 0.12 seconds. This rhythm is generally present with advanced heart disease or advanced stages of heart failure. Digitalis toxicity and metabolic imbalances can also cause this rhythm. To begin treatment, first assess the patient. Then, check the patient's records for a DNR to determine your treatment options. You may use a transcutaneous pacer, and atropine is an option, but no antiarrhythmic can be used with this rhythm. Idioventricular rhythm is a rhythm that originates in the ventricles, and an antiarrhythmic would wipe out ventricular activity.
Accelerated idioventricular rhythm follows the same criteria as idioventricular rhythm, except that the ventricular rate is more rapid, with impulses firing at a rate of 40 to 100 beats per minute. On an ECG of a patient with accelerated idioventricular, you will see a regular ventricular rhythm at a rate of 40 to 100 beats per minute and a wide QRS complex greater than 0.12 seconds. You will also note that the T wave often runs in the opposite direction of the QRS complex. The basic ECG characteristics for a patient with accelerated idioventricular are as follows. Rate, 40 to 100 beats per minute. Rhythm, ventricular is essentially regular, but the atrial is not usually discernible. P wave, none identified. PR interval, none measurable. QRS equal to or greater than 0.12 seconds. Accelerated idioventricular may present with myocardial infarction and is common after reperfusion therapy. It may also be present with digitalis toxicity and rheumatic and hypertensive heart disease. As always, first assess the patient before beginning treatment. If the loss of atrial kick has caused the patient to be symptomatic, there are two good options to consider. The first is the administration of atropine, and the second is transcutaneous pacing. But as we learned earlier, we do not want to give an antiarrhythmic drug that could suppress this ventricular rhythm because it is made to protect itself and may resolve on its own.
Our last two rhythms are the most grave and result in the poorest patient outcomes. The first of these is asystole, which occurs when there is no cardiac output, no ventricular rhythm or rate, and no pulse. In this state, the heart has lost all of its electrical activity, and there is no electrical pacemaker to initiate electrical flow. It's the complete and total absence of atrial and ventricular activity, which is why it is known as the straight line. This is a lethal rhythm. Causes for asystole may include extensive myocardial damage, drug overdose, respiratory failure, or cardiac arrest. Once again, treatment begins with assessing the patient. In this case, you must check for a pulse and confirm that it is a true asystole by checking for a rhythm in another lead. Then you will call a code, begin CPR, IVIO, and intubate. As with any pulseless rhythm, appropriate CPR practice is critical to maintain adequate perfusion and ventilation. The appropriate drug intervention would include epinephrine. Administer epinephrine as a 1 milligram IVIO every 3 to 5 minutes with no maximum dose. The goal through these procedures is to find and treat the underlying cause of the problem.
The second of these rhythms is pulseless electrical activity, or PEA, which is actually a clinical situation, not really a rhythm. The monitor may show a normal sinus rhythm that looks viable, but the patient is dead and has no pulse. While there is electrical activity, there is absolutely no perfusion, no mechanical function, no pump equaling no life. The monitor may show that the patient has a sinus rhythm that is viable, but there is no pulse. There are several possible causes for PEA. You can remember them by H's and T's. The H's are hypovolemia, hypoxia, hydrogen ions or acidosis, hypo or hyperkalemia, and hypothermia. And the T's are tension pneumothorax, cardiac tamponade, thrombosis, coronary or pulmonary, and toxins. H's and T's should be noted for all pulseless arrhythmias, not just PEA. Although it may seem like the effort would be meaningless, it is still important to go through the process and assess the patient. Determine and treat the cause if it's not too late. Treatment sequences include CPR, IV, IO, and intubate. Epinephrine should be administered. Administer epinephrine as a 1 milligram IV push every 3 to 5 minutes with no maximum dose. Stay focused on doing everything you can to find and treat the cause, even though there is generally a poor prognosis with PEA situations. Never give up until all your options have been exhausted.